Okay, so it's another case, and good morning, by the way. So my case is a 69-year-old lady, history of diabetes, dyslipidemia, and obese. Her weight around like 100, 105 kilogram. She presented to clinic with shortness of breath and dyspnea on exertion, as well as lower extremity edema. We're talking about 3 to 4 plus, mild ascites, and she visited the ER at least twice before the clinic. They refer her to our clinic. And then we did echo as an outpatient severe TR. And then down the road, she actually admitted again with heart failure symptoms. You know, and that's her echo transthoracic. We can see the TR. And, you know, after we started diuresis, medical therapy, we decided to do coronary angio just to prepare her for, you know, tricuspid intervention, because this is isolated TR. And coronary doesn't look bad at all. And at that time, we did a right heart cath, and you can see that the biventricular filling pressures are high, maybe more on the right side. RA is 15, RV-EDP 14, with wedge pressure of 15. So this is the TEE. That's kind of confirmatory. You can see the TR. It's kind of wide open. And you see on the last picture, the coaptation wasn't that perfect, wasn't that good. Then, you know, we discussed her in our heart team meeting, and we did SDS score, and that's what it looks like. It's kind of intermediate to high risk. And this is further TEE. And you can see here on the left side, there are multiple, we're seeing at least 4 leaflets, maybe more. And on the right top side, you know, the jets is coming from everywhere, basically. So multiple jets. So I guess we'll stop here.
Yeah.
We, you know, discussed her. She's a obese lady with kind of intermediate risk and isolated TR and symptomatic, including ascites and lower extremity edema, rehospitalization, and ER visits.
Definitely a tough case. So we'll ask the panelists here. Dr. Balghath, will you offer a tier for this patient?
I think we face such cases, most of us in our practice. And when you see they're suffering with multiple ascites, like, you know, they come to the emergency, you do the tapping, they feel better for 1 week, then they come back. We were so happy with the introduction of the Triclib and Pascal in our area, and we treat a good number of the patients with it, as the patient I showed. But this is totally different. I think she's not a good candidate for surgery. I can talk on their behalf. This is not the best case to be done surgically. And luckily enough, they introduced this new technology of bicable, like tract valve in our area, and we use it in some of the patients. I think she could be a good candidate for the bicable.
Dr. Bakhar?
Yeah, thank you. I would also agree that this is not a good setup for a tier. I don't know how much the patient could potentially be optimized, but I doubt that there's going to be significant enough opportunity for tier. Surgery, I don't think we have good enough data to show that that will be a benefit. Now in the US, where I am, we now have FDA approval for the Evoke valve. Again, being a challenge here with the size, this is too big of an annulus. I don't think it would be an Evoke candidate either. So I agree that a bicable trick valve may be the best option for this patient. Comes too late to the presentation, right?
Well, Dr. Rashdan, would you offer surgery for such patient?
Well, I mean, Dr. Balghath, I think he is an intervention cardiologist, and he took the role of the surgeon. So he's
because I know you for a long time.
Yeah. Look, I mean, she's 69. She's obese. She does not have pulmonary hypertension, as heart cath showed, and her wedge pressure is 15. So the question comes: why did you develop isolated TR? Is it like so? Is it like issues with the RV? Is just the annulus get dilated? There is some so. But however, in these kind of patients, I still offer them surgery. We could do it with moderate risk with minimal invasive beating heart without cross-clamp the heart, and we have a good outcome. But if we as a heart team thought this patient is a high risk and it will be suited better by alternative option, it's also we'll consider that.
Can I add a small point? A lot of time, we discussed the patients in the combined meeting. And then the surgeon, to be honest with you, they don't refuse in the same time, but they said, we will go and see the patient in the room. And whenever they go themselves, not their fellows, they change their mind because the phenotype of the patient is totally different.
Okay, Dr. Salem, show us what you did.
Okay, go ahead.
Back to the slides.
Can we
Yeah,
advance
you're
the
on the
slide?
slide.
You're on
You're
the
still on the
slide.
slides. Keep going.
It's from them.
It's
not
frozen as
advancing,
yet.
but-
Go ahead.
Okay, so we thought, basically, okay, so basically I thought it wasn't a good idea to clip, to be honest, because of the evidence that I showed you, the 4 leaflets and more. Also, the coaptation gap was 12 to 13 by our measurements, and the cutoff basically is around 7 to 9. And the jets were everywhere between the intraposterior, intraseptal, basically everywhere. So again, in the heart team, we said a high risk for surgery, obesity, frailty, intermediate to high risk, turned down twice, actually. We visit, the surgery idea twice, and she was turned down clearly twice. And then it was not suitable for TEER, so the heart team decided on bicable trick valve. And to do a bicable trick valve, you need a very good imaging, and it's basically on the CT. And luckily in this patient, the venous, the bicable, the SVC and IVC are actually very good and not tortuous, and the size is relatively good. So the first pictures, you look at the SVC at the level of the mid-PA, and you take a diameter. Then also you look at the length from the precucephalic junction to the mid-PA, then to the SVC-RA confluence. That is to accommodate the valve. And why mid-PA is important? Because you want to put the belly of the valve there to seal very well and to anchor and not cause embolization. So again, the diameter was around 21, and we allow for 2 to 3, maybe even 4 oversize. So the valve that was chosen is 25, based on that. And then you look at the RA-IVC transition diameter, but very important to look at the hepatic vein, ostium, and the length between the ostium of the hepatic vein as well as to the RA-IVC junction, because you want to land the valve there. You're allowed to protrude the valve a little bit in the RA with about 2 to 4 centimeter, but also keep it, don't occlude the hepatic vein altogether, all of the hepatic vein. So basically the size we choose is 31, which is a smaller size for those patients. Then you guide your intervention by fluoroscopy, basically, with the help of echo for sure. So you place a pigtail on the on the left precucephalic. Then you try to put the belly at the level of the mid-PA and above, and then you deploy the valve from top bottom, and this is the final for the SVC.
Can we see the hemodynamics?
Then for the IVC,
The
you put,
hemodynamics after that, Dr. Salem?
Go ahead.
The hemodynamics after this.
fantastic. I'll show you.
Yeah.
So basically, you put the pigtail on the hepatic vein. Then you start at the junction, maybe a little bit above, protruding in the RA. Then you start deploying the valve. Actually, the valve at the top of the cells. And this is the IVC pressure pre and post. 32, it dropped to 19 after that. And you can see that the valve on the right side. On the right side, you see on the left side of the screen. On the left side of the screen, you see the SVC. Good seating with small, tiny PVL, trace. And then on the right side, you see the IVC sitting perfectly, no PVL. So follow-up, I saw the patient 6 months and 1 year after. She was doing well, no more ER visits. She's still on Lasix, furosemide, but decreased to 20, lost some weight, and no ascites or lower extremity edema.
Thank you.
Thank you.
Thank you.